Okay, so without, in the interest of time, we'll just get right to it. So by the end of this talk, I hope that you'll be able to give a good definition of neuroinflammation and maybe give some examples of neuroinflammation. And more importantly, discuss the biological mechanisms of neuroinflammation, how it happens and what it's for. So that's the idea, and that's what I'm going to try and do in the next half hour, 45 minutes. Now, we all know what inflammation is. I think every single person on this Zoom call has experienced inflammation many times. And by experiences, for example, this person hit their leg on a table and has got a bruise. That is an inflammatory response to trauma. Another thing that I hope you haven't experienced, but in the States here, we have a bush, a plant called poison ivy that has a toxin urushiol, and that generates a skin inflammation as a response to touching this plant. Sun radiation, right? The UV, the ultraviolet rays, can cause sunburn on any different skin type. It doesn't matter. Not surprisingly, but X-ray radiation, like we use to treat cancer, generates the exact same response from the skin. This person was unfortunate. They were building something using a glue gun, which heats up these little rods and sticks and gets the glue hot, and then it sticks to things. Well, he glue gunned his hand. So burns can cause an inflammatory response. On the other side of things, I live in Minnesota, and every year it gets very cold, so minus 20, minus 30 Celsius. That's just our normal winter, and this person has frostbite. So their toes got frozen, and that generated an inflammatory response. Some people are prone to getting ingrown hairs. They grow in and under the skin, and those get infected, for example. So this is a boil from a bacterial infection. And this person had chicken pox, which is a herpes varicella zoster viral infection. And so these are the pock marks that you get from that. Luckily, they have vaccines now. So a lot fewer people are getting chicken pox now than did when I was a kid. I got that. So you can see that we all know what inflammation is. We've all experienced inflammation in one form or another. And gee, about 2,000 years ago, this Roman named Celsus also was the person to first describe inflammation, but he used things that he could see to describe it. So for example, all of the cases that I showed you had swelling, redness, pain, and warmth on the skin. And his word he chose for that is inflammare, to set on fire, and that's what we use for inflammation today. That's kind of an old definition. So something more modern with modern medicine is that inflammation, a protective reaction of the body against injury or infection, right? And that seems a little more workable for the medicine that we have these days. Now, the inflammatory system is fully integrated in every tissue of your body. Every tissue can react to some sort of challenge using these inflammatory pathways. The key thing is that it works closely with the immune system and can call for help, if you will, from the immune system, but it is a standalone part of your body. And so think of it like the first responders on the scene, and if they need help, they'll call up the immune system for extra help to treat whatever the insult was. The bottom line is you need inflammation. It's vital to your health and well-being, and if we didn't have an inflammatory response, we would not have a long lifespan. So why has this evolved or been created over time? Well, we covered some of these: defend the body from attack, from viruses, bacteria. Lots of things are out there that could kill us, right? And so inflammation is the first response to those things. Not only defending, but repairing the body when the body is injured is another role for inflammation. And then more recently, we've noted that inflammation can prevent cancers. We're just learning about this. There's an immune surveillance theory of cancer that people make cancers all the time, but the immune system detects them and kills them before they become a problem. And we're seeing a new group of immunotherapies to help treat cancer in people that are working quite well. Now, occasionally inflammation, like all systems in the body, can be faulty. And so you might have a slightly overactive immune system. And this will manifest like things like seasonal allergies, food allergies, contact dermatitis, things like that. But if the inflammatory system pulls in the immune system, then we get autoimmune disease. And in the United States, this is a big problem. About 3% of our population has an autoimmune disease of some sort, around 12 million people. And I've listed them in order of prevalence. And I imagine that it's different where you guys are. But autoimmune disease is a big problem in the US. And I myself have Hashimoto's thyroiditis, for what it's worth. So now, challenges. Despite having great microscopes and electron microscopes and labs filled with equipment and many, many research working on inflammation, we still don't really understand how it works. For skin inflammation, it's fairly obvious, right? You look at the skin, you touch the skin, oh, it's warm. Oh, did that hurt? You can look at all the components of the inflammation. But for other organs, it's more challenging. Inflammation of the liver, a little more difficult to palpate the liver. The lungs, how would you do that? And of course, the ultimate is brain and spinal cord. There's just no way to visually or even any physical exam to see inflammation in the brain and spinal cord. So I would argue that assessing neuroinflammation in the CNS, central nervous system, is one of the great unmet clinical needs of our time. And we're going to focus on this as we go forward here. So we need better tools. We don't have great tools for neuroinflammation. Now, since you're all neuroradiologists, or at least are familiar with neuroimaging, that sort of thing, I thought I'd present a bunch of cases here. We'll present 5 cases, giving examples of the inflammatory system at work, right? So our first case here is a 60-year-old person who has headaches and fever and chills. And they presented to the emergency room, and we got a scan, and you can see all your basic imaging sequences, your T2 flare, a T2 susceptibility weighted imaging, and a post-contrast T1 image. And it's pretty easy to see that there are things there that don't belong. So you have these rim-enhancing mass lesions. They've got a little bit of edema around them, no hemorrhage in them. These are all important things. And as we teach our residents here, this is a classic case of the ring-enhancing mass lesion, right? So we teach that this, has a differential diagnosis. You can't tell just looking at the imaging exactly what it is. We can get close, but we do teach this as the magical doctor differential. So you can see metastasis, M, abscess A, G for glioblastoma, and so forth down the line. And so as I'm teaching this, I asked the resident to recite back, if you will, the magical doctor differential. And then I'll ask next, okay, can you add any additional imaging to help sort out all these differentials, kind of narrow it down to what it could be? And I hope that the resident says, well, Dr. Port, I need a diffusion weighted scan. Because if they do, then I say, great, here it is. And here you can see that the content of these cystic masses has restricted diffusion and decreased ADC. And this is fairly specific for an abscess. And in fact, this is exactly what this turned out to be. This patient had abscesses from Staph aureus from their skin. What would have been nice, and I would love it if you would invent it, would be a bacteria scan, right? Diffusion gives a good clue as to what it is, but this could also easily be lymphoma. If I had a bacteria scan, there'd be no question, right? Unfortunately, we don't have one. Okay, related but different case. This was a 71-year-old lady found on the floor of her house, unresponsive, brought to the emergency room. And I think you can see that there's some hydrocephalus going on here. The ventricles are enlarged, maybe a little transependymal CSF flow, maybe a little restricted diffusion. You might say, aha, this is an abscess, but it's not a mass, right? It's just lining the ventricles. You give some contrast on the MRI and nothing enhances. But luckily, the radiologist who is covering the ER this day said, okay, let's get an MRI, but I want you to add a post-contrast T2 flare image to the exam. This is in addition to what we normally do. And so here you can see, here's the T1 with contrast. Here's the pre-contrast T2 flare, and here's the post-contrast T2 flare. And I've taken great care to make sure that the window and level settings on these are exactly the same. And they are. So can anybody see a difference between the two flare images? This is subtle, but it's here. Let me give you another view. Here you go, another cut, a little bit higher up. Any differences that you could see? Okay, another cut down in the cerebellum. There are subtle differences here, but when I point it out, you'll say, oh, yeah. So here are two separate cuts, okay? I hope that you can appreciate it, and I hope it comes over on the Zoom. It might not. That the CSF in the sulci is much brighter, well, somewhat brighter than the CSF on the pre-contrast, right? There's a lot more enhancement of the leptomeninges on the post-contrast T2 flare. Here, again, subtle, but look at the enhancement in the sulci here versus on the other side, the pre-contrast, right? And this is what you get when you're looking for a leptomeningitis. It's not much. I wish I had a bacteria scan, but this is it. Okay, so this is pretty classic for a leptomeningeal disease. And in fact, yes, that's exactly what this patient had. Okay, next case, I'll give you an example. This was a 50-something year-old lady who got the flu and then developed a rash on their back in a radicular pattern, and everyone thought this was shingles. She was tested for herpes virus, and it tested negative, and in fact got worse. Eventually had urinary retention, lost the ability to walk. And so this was the very first scan at an outside hospital, and you can see that the spinal cord on these T2 images is swollen. It has T2 hyperintensity in it. Here you can see the central part of the cord is all swollen. And then there's this patchy enhancement within it. So this is great. We found the finding that's explaining what's wrong with her, but again, we're stuck with a differential diagnosis, right? So this is an acute transverse myelitis, but the differential diagnosis includes all these things. So mechanical cord compression, we don't see that, but any of these other things could be the cause of this. And again, this is where radiology is stuck. We don't have a scan that can help. But luckily, our neurology colleagues do. They did a blood test, and this patient has antibodies to aquaporin 4, and that is responsible for the disease neuromyelitis optica. So this is an autoimmune disease, neuromyelitis optica, with what turn out to be typical changes in the thoracic cord. So how does this go over time? Well, this is inflammation at work, right? The cord is inflamed, it's angry, but we treated the patient properly. We got rid of the antibodies to neuromyelitis optica. And over the next few months, you can see that the swelling went down, the enhancement went away. And by 4 months out, there was just a little tiny scar in the cord, but inflammation had gone, the good kind, and it just cleaned up all the damage, right? So you need inflammation. Here's another case that's pretty straightforward, actually. You've got, not much on the T2 flare, T2 or susceptibility-weighted imaging, but this patient had an acute right-sided blindness. And here you can see, left-sided blindness. Here in the right occipital cortex, you can see an acute infarct going on, looking at diffusion and ADC. Restricted diffusion and a vascular distribution, piece of cake. Okay, so the patient was treated, and as we usually do, we'll follow them up at a month. And when we got that scan, we saw that within the infarct, there was suddenly new hemorrhage, right? So this is T2 bright, T2 flare, was bright in the center, dark in rim. On susceptibility imaging, you see all this darkness from blood. And of course, on the T1, you see all the brightness from acute to subacute hemorrhage in the infarct. Luckily, the mass effect wasn't that bad, and it didn't spread any worse than this. But over time, the inflammatory system continued, and it cleaned up the blood, and it cleaned up the necrotic occipital lobe here. And that, again, inflammation critical for healing. All right, last case, a little bit tricky. This is one where the patient presented with the exact same blindness, but on the other side. So they had right-sided blindness. And here you can see this process going on in the left occipital lobe. Diffusion is bright, and you might say, well, this is an infarct, but it's not, because it doesn't go to the cortex. It just stays in the white matter. And Furthermore, there's this edema around it. Some goes out to cortex, some doesn't. It looks like it's heading towards the corpus callosum, and this strange rim enhancing pattern. So not a typical appearance for a stroke anyway. So by the time the patient made it to Mayo, this was getting worse. This swelling had increased. The edema now went out almost all the way to the cortex. It was crossing the corpus callosum. Diffusion still had this strange pattern with a somewhat bright rim around it, but not light bulb bright. And we had this patchy enhancement. So the surgeons here decided, just to be safe, let's go get a biopsy, and they did. And this turned out to be tumefactive multiple sclerosis. This was MS. This is a rare form, but we do see it. And so over time, the patient got the right treatment. They had Plex to take out all the autoantibodies, things like that, and got steroids, and everything cleared up for the most part. Here's the biopsy defect from where they took their sample, but all the edema is gone. Here you have some encephalomalacia, so there was some inflammatory response that cleared out all the necrotic brain, and of course all the enhancement had gone. So inflammation, mixed blessing, right? Very, very helpful at defending the body, very, very helpful at cleaning things up in the body. MRI is pretty good for narrowing down differential diagnoses, or at least helping to raise differential diagnoses. And sometimes we get it to a single diagnosis, like abscess. You have to do the critical MR sequence that helps make the diagnosis, right? So you have to have that diffusion or that post-contrast T2 flare. And some diseases don't have any critical sequences. For example, in a transverse myelitis, MRI is good to diagnose it, but fairly useless to figure out what it is. So even in 2023, anywhere in the world, MRI is limited in what it can do. So a lot of information there, hopefully understandable in given your backgrounds and everything. What I'd like to do now, we're all pretty good at the radiology part of it, but I'd like to go back and review back to the beginning with the cellular and anatomical portions of it. It's important to understand, again, the building blocks of the brain in order to understand how inflammation works. And I'll give an example of that towards the last part of the talk. Is a lot of things to keep in mind, so I'll go at a reasonable pace, but forgive me if you know all this stuff, then you're also a neuroscientist, and this will be a review for you. Okay, Neuroanatomy 101, everyone's seen the brain. It weighs about 2% of the body weight, but uses 20% of the blood supply. And there's a gray matter cortical shell, white matter core, and CSF. Nothing new for anyone here. Now, putting the brain under the microscope, let's go back to 1905. These are original drawings from Santiago Ramon y Cajal, published in 1905. Back then, we didn't know what cortex was made of. And so what Cajal did was take samples of cortex, throw them in a silver nitrate stain. Cells would be stained and become visible, and he made exquisite drawings of these cells. And so here you can see some examples of these. The cells were organized maybe in layers. They couldn't figure out were they connected or not connected. It seemed like they might be. They didn't even have names at the time. It was a few years later when someone coined the name neuron. And then a few years after that where they coined the name glia, and we'll get to that in a bit. But this started the whole thing with a cytoarchitecture and the construction of cortex. Now, over in Germany a few years later, Corbinian and Brodmann was looking at the brains in a similar fashion, but Brodmann had a different approach. He looked at different brain areas. He was the first to notice that the patterns of the cells were different in different brain regions. And in this lower frame, I think you can see, this is one of his original micrographs. And just looking at this half of the image and this half of the image, I think anyone in the room can say, well, they're different. And they are. And so what Brodmann was able to do was map out 43 separate brain areas in the human being and basically create Brodmann's maps that we still use today. Neurosurgeons use these all the time. Okay, moving forward to about the 1930s, Joseph Klinger did an interesting thing with brains. He took a brain and he put it in the freezer for a couple weeks. I guess he had to go on vacation or something. Someone can mute maybe? Okay, thank you. So when he took the brain out of the freezer a couple of weeks later and was able to dissect, he saw these tracks that were running through the white matter. And so he was able to develop a technique to map out white matter anatomy that no one had been able to do. In fact, it took 70 years for MRI to advance to the point where MRI could kind of see where the tracks were. But yeah, all this was sorted out in the 1930s. And then finally moving forward, Vernon Mountcastle was the first to figure out how cortex worked, how the functions of the cortex were organized. Now, human cortex has 6 layers, and the thought was that information traveled side to side within the layers, but Vernon Mountcastle was the first to show that, in fact, information went up and down. You went from the surface down to the bottom layer. So these cortical columns are the way cortex is organized. Forgive me, I keep getting, okay. So that is a basic review of the neuroanatomy and the history of it, how we got to be where we are today. So we've talked about neurons and glia and a little bit about vessels. The top 3 books there are ones that I used during my medical school training. If you want to really get into the cells, The Principles of Neuroscience is a great book. And if you want to learn about brain functions at sort of a global level, that neuroimaging book can be helpful. All right, let's briefly talk about neurons found in cortex and, deep gray matter structures. Only 10% of the cells in the brains are neuron, right? It's strange, but the other 90% are glia and blood vessels. The neurons themselves have the cell body dendrites and then transmit their information via the axons and the terminals, and the synapses are the connections between the neurons. The nerve endings of one cell will synapse with the dendrites and cell body of the next one. Key point, we're now aware that you constantly make and break new synapses. In fact, when you sleep, your brain is most metabolically active, making these synapses. So now that's cortex. In the white matter, the oligodendrocytes are the cells that perform myelination of the axons. And you can see, and I think probably best in this electron micrograph, here's an axon, and then surrounding it are, a dozen layers or so of myelin around this axon to keep it insulated. So it insulates the axon. There are little gaps called noses of Ranvier. And that helps speed up transmission. But if the myelin is damaged, then neurotransmission is slowed down and you can get functional deficits. We see a lot of this in multiple sclerosis, for example. Astrocytes. Now, these are found throughout the brain, and think of astrocytes as the ultimate supporting cell. Neurons would not do very well at all if they didn't have an astrocyte partner. And the astrocytes supply energy to neurons via something called a lactate shuttle. The astrocytes play a key role in recycling neurotransmitters and synapses. They serve as a support skeleton for pretty much the whole brain and form the blood-brain barrier. So astrocytes, a key cell in the brain. And actually, the vast majority of cells are astrocytes. Microglia is another glial cell line that is also distributed fairly evenly throughout the brain, and they just sit there normally, inactive. They don't do much of anything. But when there's, quote, trouble, when there's some insult to the brain, they are the first responders within the central nervous system. So if you will, these are the inflammatory system of the brain. They have many functions. They modulate inflammatory responses with innate immunity, and they can call the immune system to help out. Day to day, they're important for maintaining synapses and repairing any injuries that come up. And vessels, there's no big deal here. You guys all know this. But the one key point here is that vessels are all covered with a basement membrane, and then what they call end feet that come off the astrocytes that basically cover the vessel. They cover that basement membrane. And this forms the blood-brain barrier. So you've got a combination of cells and membranes that make up the blood-brain barrier. So you have your capillary endothelium, and these capillary cells are held together with these things called tight junctions that keep out just about everything that's in the lumen. Then you have a basement membrane, and then you have an astrocytic end foot. And the combination of all of these things form the blood-brain barrier. The purpose of this is to restrict molecules that can enter into the brain. So your brain has a fairly pure environment. Things that can get in are lipophilic compounds, very small molecules. So, for example, sugar, amino acids, that kind of thing. Lipophilic compounds, think of general anesthetic, think of alcohol, things like that. And then positive charged ions can get in. So sodium, potassium, things like that. Water and hydrophilic molecules can't enter. In fact, water content in the brain is tightly controlled by active mechanisms, and it's an active process. So the aquaporin thing that we were talking about is one of the ways that the brain and spinal cord maintain water balance. The blood-brain barrier keeps out cells, especially immune cells. We don't want those in the brain. We have microglia that will call for them if necessary, but keep those out. No bacteria, no viruses, nothing like gadolinium. That's a huge molecule, can't get across. Keeps out almost all drugs, keeps out antibodies, and it really serves as the first line of defense against attack. The other good thing the blood-brain barrier does is it keeps out anything that might be related to peripheral inflammation. So, for example, if you were to bruise your leg and it was big, swollen, had a contusion, a hematoma in your leg, your brain would be fine. It wouldn't even know that any of that was going on. So the brain really does have a privileged environment within the body. Finally, let's talk briefly about cell-to-cell communications. This turns out a huge field based around the chemicals called cytokines. These are a large group of factors that are secreted by cells. Some are pro-inflammatory, some are anti-inflammatory, and there are 6 major families. You've probably heard about interleukins and interferons, but there are a whole bunch of other cytokines that cells use to talk to each other. So think of cytokines as the vocabulary of cells so that cells can communicate. One cell will secrete some cytokines, they'll diffuse over to other cells, and those cells will listen and hear it, and they will do things. Besides cytokines, there's these matrix metalloproteinases, free radicals, complement, and so forth. This in itself would be easily a week-long lecture, so we'll just call it good. So far, we've talked about building blocks of the brain and spinal cord. We've talked about the cells, what they do, how they talk to each other. We've talked about the blood-brain barrier and how it's built. So I think we have enough background knowledge now to run through an inflammatory response and see the things that occur, the events that occur when inflammation acts properly. So we'll start with an example. Okay, we're going to use a very, if you will, a bird's eye view of the whole inflammatory cascade. Now, this is a model and it's supported by the current facts. You can see the details of those on the right side. We're just starting to understand how all this works in humans. So take what I'm telling you with caution, because I'm sure things that I'm going to explain are wrong because we don't know any better today. In 5 years, this will be more clear, but you get the idea. So we'll start with a simple example. Let's start with stroke. We'll just do a stroke example. So let's say a clot breaks off from ulcerated plaque and travels to the right frontal lobe, right? We'll say it plugs up the right MCA. Okay. So now that we've cut the blood supply off, we have a lack of oxygen that causes an energy failure with cells. Within 15 to 20 seconds, ATP levels start to fall because we can't do our oxidative metabolism anymore. And without any energy, neurons begin to die over the next, starting at about 4 to 5 minutes in. Interestingly, even after the oxygen levels fall, that early, dying tissue and cells will release pro-inflammatory mediators, such as these cytokines and reactive oxygen species. So the cells are already starting to communicate that they're in trouble as the stroke is happening. Okay? These inflammatory mediators will activate the microglia within the region of the infarct. And so here you can see on the top, you've got a inactive microglia will jump into action. And within minutes, these microglia will secrete different cytokines that will signal your vascular endothelium to express something called the leukocyte adhesion molecule. So they tell the blood vessel, hey, I want you to put up these adhesion molecules so that the immune system can see us. So the cytokines also loosen up those tight junctions. Those tight junctions between vascular endothelium will resorb. And now we start to get leaky. The basement membrane becomes more permeable. And so we've called for the immune system, and now we wait. We don't have to wait for long. The blood cells that are always circulating through your body will, as they float by and see these leukocyte adhesion molecules, will grab onto them. And through a process called diapedesis, these blood cells, these white cells, will either crawl in between these vascular endothelial cells or can actually go right through a vascular endothelial cell. This is a crazy process, transcellular diapedesis. And within minutes to hours after the infarct starts, they can appear within the brain tissue. So the immune system has been summoned to come deal with this infarct that is underway. Lots of cells migrate in using this mechanism. So the microglia from surrounding brain areas will activate and they will migrate in. These cells are very good at moving and they put out a process and then they pull themselves forward with it. There are loosely two types of microglia, the M1, which are anti-inflammatory, and the M2, which are pro-inflammatory. Both of them will migrate into the area of infarct. The pro-inflammatory ones increase to peak numbers by the first week and then decrease thereafter. The healing anti-inflammatory microglia will get in there, but they'll kind of sit and wait for the inflammatory process to be over before they start with the healing. More importantly, you've got leukocytes. Leukocytes peak at around 3 days, and the neutrophils are the first to show up. Then you get T cells and so forth. These white blood cells cause swelling and edema, and that's why infarcts swell up, right? They get in there and they start tearing apart brain. The initial response of this white cell infiltrate is to promote injury. They release myeloperoxidase and some other cytokine-like things to amplify the inflammatory response. They go and find dead tissue and they dissolve it and they get rid of it. And these can cause further damage to the area. And in fact, that can lead to hemorrhagic transformation of an infarct, as we've seen. They chew up a blood vessel that is still connected to arterial supply, and you get a little bit of bleeding, right? So this is an aggressive inflammatory response. The microglia also demonstrate some phagocytic activity. They engulf and digest dead cells and so forth. So the whole idea is to get in there and start cleaning up. So as the pro-inflammatory response subsides, so you're about 2 to 3 weeks following the infarct, the leukocytes slowly leave. The remaining anti-inflammatory M1 glia, they start secreting more cytokines and growth factors that promote neurogenesis and healing of the neurons, angiogenesis, getting new blood supply in, and you can get some new cells coming in. They also release interleukin-10, so that's a cytokine, which shuts down the expression of those cell adhesion molecules. So now the white cells in the blood will just go right past the infarct and never stop, right? So we've stopped attracting any kind of immune system response. And then over the next few months, reactive astrocytes will migrate to the site of the injury. They'll accumulate and form a glial scar. And this will protect the normal brain, and it will kind of wall off and reestablish that very special environment that the brain has. Whew, that is a lot of information. And so we'll spend a peaceful moment and reset and wrap things up. So I hope I've been able to show you that neuroinflammation is complex. It's a dance of cells, cytokines, and migration and all that designed to protect against injury and infection. 2023, we're just starting to understand how different processes all work together. And our neuroinflammation tools are primitive. We need better MRI sequences. I would love an inflammation scan. I would love a white blood cell scan that would say, hey, you've got a bunch of white blood cells in the brain. That would be helpful. So very much to do. We need the whole world to get on board developing these great tools. And so let's get to it. I appreciate the time and opportunity to talk about this. If you want to learn more, I was privileged to be able to participate on this as one of the editors. This is a new book that just came out in April, and we've got experts from all around the world that help us create this book specifically on neuroinflammation. So Thanks very much for your attention.